Disorders of sexual development have often been considered as a medical and a social emergency. But what's been often ignored that it is actually an emergency for the doctors who rush towards going to the books, to the various things as to how to evaluate an individual with DSD. iDSD will focus on the entire aspects of disorder of sexual differentiation, ranging from pathophysiology to classification to evaluation and management to iDSD, which is going to focus about disorders of sexual development, which is a very intriguing topic, a very interesting topic, which is often causing a lot of confusion with regards to evaluation and management. Website learning.growsociety.in, from which we are webcasting this event, where we have got multiple options available for learning in the form of our master pediatric endocrine course over 18 months, covering nearly now 100 modules on everything related to pediatric endocrinology. So if you want to learn, you've got each and every aspect which is there, using videos, using text, pre-test, case scenarios, and everything available. We have recently launched a pediatric endocrinology for postgraduate program, which again is covering a number of learning modules specifically for postgraduates for a 3-year period. All of you can have a look at a book which is available, and along with that we have the mobile application basically, which is covering in that perspective the various aspects of management of pediatric endocrine disorders, including the approach pathway, the management pathway, the personalized management care, and there are various ways you can use. It's a very intuitive form in terms of evaluating patients with different disorders of pediatric endocrinology. And these are available on Android and iOS. When you say sex chromosome DSD, it's a term which has now been used more often, especially after the DSD classification, the newer classification which came up into the fact, and it actually includes terms like Turner syndrome and Klinefelter syndrome. Now, those should not ideally be considered as DSD, because when you say Turner syndrome, the diagnosis itself excludes atypical genitalia in that regard. So when you talk about sex chromosome DSD, in our perspective from a clinical situation, we are talking about situations in which you either have got a mosaicism of X and Y or a chimerism, and both of them will have a difference. So what is the difference between mosaicism and chimerism? So when we say mosaicism, it is a post-zygotic defect. So in post-zygotic defect, what's basically happening is that you have got one cell line which is having a normal cell type or a different cell type, and the second one is the different cell type. So it's a post-zygotic, and the manifestations will depend upon which particular cell types are affected and which cell types are expressed in different areas. When you talk about chimerism, it basically means the two cells have fused so that you've got an extra chromosome, and that causes confusion in that regard. So we'll go one by one. So one common presentation here is a XXY mosaicism. So you should not confuse this with Turner syndrome. Many of girls with Turner syndrome will be X0 and they may have XY, but they would be phenotypic female. That's very, very important message out there. The defect here is post-zygotic. It will be variable. So depending upon which cells have got X0 and which cells have got XY, you may have development of one particular gonad in one area, the other in the other area in that perspective. So gonad usually would be a normal or a dysgenetic testis and a normal and a dysgenetic ovary. So depending upon where you have XX, you will have a different X0, you will be like a Turner syndrome like presentation, and XY will have a testicular development which happens. And of course, streak gonad may happen if it's a X0. The features are that, of course, if you have one particular area behaving like testis and one particular area behaving like ovary, they will be genital asymmetry. So if you have got a asymmetrical genetic appearance, always consider the possibility of a XXY mosaicism, which becomes important. And as Pratik will discuss later on, they have a huge malignancy risk, and this is something which we need to be really bothered about, because this Y chromosome can cause a problem. The other thing to remember is that if you have mosaicism, depending upon which one is predominating. So if you have a predominant Y mosaicism, this will behave like a male appearance, and then they may develop feminization. So they may develop suddenly gynecomastia. So if you have unexplained feminization at puberty, start thinking of a XY mosaicism, which is predominant. If you have a predominant XO with a XY which is minor, they will present as a normal looking female also with virilization.
So during puberty, if you have feminization or virilization, start thinking of these funny things. Of course, besides the AIS, besides the 5-alpha reductase in that regards. Now, many of these features, if you have X0, effectively will behave like Turner syndrome. Now, what really is Turner syndrome? Turner syndrome is the deficiency of the pseudo-autosomal genes. So if the same genes are defective, you may have short neck, you have lymphedema, you may have cardiac defects. So all the classic Turner risk will apply to them. So although you are not labeling them as Turner syndrome, the risk for hearing, the heart, and all those things are pretty similar as compared to the Turner in this situation. The other situation is a Y chimerism, in which you have a normal XX and the Y has fused in that. So these two cell lines have fused basically. It's a zygotic fusion, and this will behave like a 46XX and you have a XY. Gonad here would be a bit different. You may have a normal or dysgenetic testis, normal or dysgenetic ovaries, and a streak gonad may also happen. Features will again be genital asymmetry. You will have Mullerian structure on one side maybe and testis on the other. So this is a very strange combination which may happen, and gonadectomy again becomes important. So there's a subtle difference between Y chimerism and a X0, XY mosaicism in that perspective. There will be no features of Turner syndrome out here. The other complicated situation is, of course, ovotesticular DSD. So when you say ovotesticular DSD, you want to say that there is a ovarian tissue and the testicular tissue in the same individual. The defect here is again mosaicism, which is at the level of the gonad. So it's not a systemic mosaicism. Only in the gonads you have a differentiation, and you can either have an ovary, testis, or an ovotestis. When you basically say that this is an ovary, you have to document a granulosa cell out there, and you have to document a Sertoli cell for it being to be testis. So this needs to have a histological confirmation of both testis and ovary, and that's essential for this ovotesticular DSD to be there. Management is difficult, and we'll discuss this in much more detail, and gonadectomy may be required at the end in that regard. So this is